So I would like to introduce Professor Daniel Seidman. He's a professor at the Tel Aviv University, finishing medical school at the Hadassah University in Jerusalem, being trained in Stanford in fertility surgery. He's a publisher of over 250 papers, and he came and visited us around 2.5 years ago. Daniel, is that right?
Right.
He comes from a country not far away from here, having being the clinical director of the Asuta Medical Center, which is a center with over 15,000 pickups and 30,000 frozen cycles annually. He would like to collaborate with a big center like ours, so this is how everything started. Daniel is going to talk about selecting smarter AI-enabled PGTA and how this helps embryo implantation. Daniel, it's a great honor and pleasure to have you here, and the floor is yours.
So first, I'd like to really appreciate all the brave people who stayed in the hall so late. I'm not sure in Israel we'd have such a great audience so late, so I really appreciate it. And also I would like to thank Ionis and the group in Nigeria for the collaboration we've had for several years, and it has intensified over the last year, and I hope this is a sign that the collaboration will continue to grow, and I think there is growing collaboration in general between Greece and Israel, and we really appreciate that. So now that you know everything about how AI is developed, I'm going to give a much simpler talk about the clinical aspects. And again, I disclose that I'm also a co-founder and a chief medical officer of AIVF. Now, I think this audience is very familiar with the fact that aneuploidy is the leading cause of recurrent implantation, miscarriage, all the things we are afraid of. And as the previous lecturer talked about age, we know that it's very strongly age-related, but in all age groups, there's a large proportion of aneuploid embryos. Currently in the USA and in a growing number of places in Europe, like in Italy, the gold standard has become to do morphology and combine this with PGTA, where PGTA provides an accurate diagnosis of the chromosomal status of the embryo. The problem is that PGTA is expensive, requires much expertise from the embryologist, and adds a lot to the cost of the treatment. So it's clear to everybody that there is a demand for an alternative test that provides a quantitative embryoploidy risk assessment. And I'd like to point out that doing follow-up of pregnancy, we are very much used to using both diagnostic tests like NIPT or amniocentesis, but we still use screening tests like nucleotranslucency and others. So the concept of using something that is not genetically diagnostic, but is an effective screening test, is something that we've been used clinically for decades. Now, a diagnostic test actually confirms the presence or absence of aneuploidy, and typically we use it for high-risk cases, but again, in the USA now they use it for practically all high-quality embryos. And of course, the strength of diagnostic tests is that you get a very accurate pinpoint diagnosis. On the other hand, screening is intended to characterize genetic risks. It doesn't give you a diagnosis, it tells you, is this embryo at high risk or low risk of aneuploidy? And although not diagnostic, having this likelihood of aneuploidy score could be and is very effective. Again, Daniela went beautifully through how complicated it is to develop an algorithm. I'll just mention that what's special in the algorithm that I'm presenting here is that it usually when we look at AI models that are trained only at the outcome. Was there a pregnancy or no pregnancy? Here we had 5,000 embryos that we also knew whether they were haploid and aneuploid. So our algorithm is based on both these algorithms, and we also added maternal age because everybody knows, tell me the age of the patient, I'll tell you the chance of aneuploidy. So any predictive model must be better than just telling us the age. Now, there's a strong bias problem in most algorithms, AI algorithms developed so far, because they are always trained on the knowledge of pregnancy or no pregnancy. So the problem is that the model only looks at embryos that the embryologist decided to do the transfer, and then we know if there's pregnancy or no pregnancy. So there's a big selection bias. And in the literature, a lot of people are talking about that there's training only embryos that were chosen by the embryos causes the fact that a strong bias where those embryos that were not transferred are completely invisible to the algorithm. And this leads to what's called a self-fulfilling prophecy bias, where the AI reinforces human bias. I mean, the whole concept of AI is to have an objective measure and not just to strengthen the decisions made by the embryologist. On the other hand, when you look at our model that was trained on PGTA assessed embryos, it's much less biased because we look at all the embryos. We don't, it doesn't matter to us if it was subsequently decided to transfer or not to transfer the embryo. So, and also this much strongly reflects the biological ground truth, because we know what's really important is, are we transferring haploid or aneuploid embryos? So we think that this bias is much less in our algorithm. Now, we use the confusion matrix, which is a high word just saying that we divided the actual and the predicted ratios into true positive, false negative, and so on. And this is the customary way when you try to assess a screening test. Now, I'll show our results, of course, and the first thing, as Daniela said, is to do a sanity test. Are your scores, do they make any sense, or are they just numbers? And the first thing we did is to look at the influence of the distribution of our scores based on the age. And as you can see, the higher the age, the lower the score, and the lower the age, the scores are higher, and also the bell curve is wider. And this, of course, makes a lot of biological sense. Also, we grouped our AI scores to predict aneuploidy into 4 groups. And again, you can see this makes sense. There was a linear increase in the AI score with the predictability of the embryo being haploid. So again, the sensibility score was proven. We also wanted to see how it reflects pregnancy or no pregnancy after we trained them only on an haploidy. And again, you can see that the chances of having a positive fetal heart was significantly higher when you had higher AI scores for haploidy. Another interesting question that we wanted to look at is, I just told you we can't give a diagnosis, and we don't have enough cases yet to train whether it's trisomy or monosomy. But we could divide it into a complex aneuploidy, where you have more than one chromosomal aberration, and regular aneuploidy. And again, we found a highly significant difference in the scores between haploid embryos and aneuploid embryos, but also between aneuploid and complex aneuploidy. So this, again, all proves that there's a biological sense to our score, and before we apply it clinically. And again, we were very much afraid of bias, because my critic as a physician was always, oh, you know, give me the age of the patient, I don't need any scores. And so we wanted to be sure that this is not the fact. So what we did, we took a subgroup of 66 patients that each one of them contributed an haploid embryo and an aneuploid embryo. And then we tried to see, does the prediction work? Because every patient was represented in both groups. So if you have a bias of age, ethnic origin, previous failures, it doesn't matter, because each patient contributes one embryo to both groups. And again, we found that there was a statistically significant difference in our prediction, even in this subgroup. Now, we also wanted to see whether this has any clinical meaning at all, and we found actually that this is a very strong predictor. Like, I'll give you an example. If the embryo has a very low score, which we defined as less than 28, 85% of the embryos were aneuploid. So this is a very strong number, and clinics that have started using this, it helps them, for instance, to make a decision whether you should freeze or not freeze an embryo. They've recorded a 30% decrease in embryo freezing, because we know we often freeze embryos where we think they're lousy, but we're not sure and we don't dare. But if you also have a score that tells you that it's 85% aneuploid, this can be clinically very helpful. Also, we found that if you compare a low-scoring embryo to a high-scoring embryo, it's 3 times more likely to be aneuploid if the score is low. And again, these are the percentages. You can see that if you have a low score here defined as less than 32, the embryo is 80% likely to be aneuploid. And on the other hand, if it has a high score over 67, you can predict 70% of aneuploidy. Again, we wanted to validate this data, so we did a few studies that I'm going to show. One of them was in 4 clinics where we used unbalanced data set, which means we didn't look at the distribution of the age, and we had an AUC of 0.7, which is of course much higher than chance, which would be 0.5. But then when we looked at a balanced blind test in 2 other clinics, again we find again the specificity went up and the sensitivity went down, but overall our predictability was very much the same. When we give the scores, again, we thought instead of giving a number, it's much easier to clinically use the likelihood of aneuploidy or euploidy, and I'll show you this in a minute. We just got our paper accepted for publication in RBMO online, and I'm going to show you again some of the numbers that we published here. Again, the background was very similar to what I just stated, that we know that euploidy is very important, and our goal was to find a non-invasive AI-based model. And again, we trained the model on almost 5,000 embryos, and in this test, which was done in EV Valencia, they looked at 700 embryos where they knew the PGTA outcome, and again, we used the time-lapse videos. And our key results were, again, that the model was very effective in differentiating between euploid and aneuploid embryos. Again, higher scores, higher euploidy, and also higher prediction of heartbeat. And there was consistent performance across the data sets. And again, we built these 4 brackets of slightly defined differently of scores, because here they're more balanced to 25. And again, you could see a very strong linear correlation where if you had a score of over 76, the likelihood that this is an euploid embryo is over 90%. And again, we looked at complex aneuploidy versus aneuploidy, and also in this data set, this was highly significant, the ability to differentiate, which shows a very strong biological sense. So we concluded in this paper, which is now in press, that our euploidy estimation is effective and can readily help any clinic. And of course, we're now continuing prospective clinical validation studies, and again, we think every clinic should calibrate this model. 2 independent studies that were published in July in the ESHRE in Paris also used our algorithm, and they very much try to see where the genetic algorithm adds to our already published pregnancy predictive algorithm. Again, they looked at 700 embryos that all in the year 2024. And you can see what they looked at the viability algorithm, the one that predicts pregnancy or no pregnancy, and you can see there was no statistically significant difference in the scores. 4.4 for haploid embryos versus 4.3 to aneuploid embryos. But when they looked at the genetic algorithm, there was a statistically significant difference in the score, 45 versus 38. So it shows that there is an addition, a significant addition, for using the genetic algorithm over the viability algorithm. And again, they looked at a number that they chose, a 50-point cutoff. And again, they showed that for embryos with a genetic score of above 50, the chances of haploidy was 70%. And when they took a higher cutoff of over 80 in this data set, actually they could put, the prediction was 100%. None of the embryos, the haploid embryos in this data set had a score of less than 80. So they concluded that the genetic algorithm outperforms the viability-based model, and it was really important because it showed that this is a clinically viable addition. The second abstract that was presented at ESHRE also wanted to see the clinical usefulness of this genetic algorithm. Again, they used Asserbier scores compared to automatic AI-generated scores. And I find this graph very interesting because if you look, they first looked at the Asserbier score, and you can see that there's a good differentiation. If you had a grade A embryo, it was 80% likely to be haploid versus a grade C embryo, which is only 40%. But if you also were able to use the genetic algorithm, you could take only grade B embryos, which are always really tough because we know that not all B quality embryos are the same. And you could differentiate. Now, if you looked at the score, you could see that within the same group of embryos that had a grade B Asserbier score, if you use the genetic, you could see some of them with high genetic scores had an 86% chance of haploidy versus grade B with a low genetic score had only a 50%. So this means that it's really a clinical useful tool because we all know to differentiate between grade A and versus grade C and D, but within these groups, within grade B, it's often difficult to decide which embryos you should transfer, which ones you should maybe biopsy for PGTA, and which ones you should freeze. And they found in EV Valencia that this was very helpful for them to making such decisions, and they concluded that the combination of morphological grading with an AI-based genetic and viability algorithm enhanced the accuracy and to predict non-invasively the haploidy of the embryo. So it seems that these genetic algorithms are a real progress and a real helpful clinical tool. So I'll summarize again what AIVF genetics offers, and I'm really proud that AGI is one of the first centers in the world using them. So this really shows progress and shows the devotion of AGI for excellence. And again, this is the way these are the way you see the embryos in our program. We divided it into high likelihood and likelihood of haploidy versus likelihood aneuploid and high likelihood of aneuploidy. So every embryo gets two scores. One, the AI prediction score for implantation, and below the quality, the prediction of its genetic makeup, what are the chances that it's haploid or aneuploid, and this is very helpful for making clinical decisions. Of course, we have concerns with AI, so nothing is perfect. Daniela went extensively over the black box thing, which is a real concern because as clinicians, we never trust numbers. And when you come in and tell us, oh, trust me, this is the way, we really want to be sure that the biological sense behind it is strong, and this is the paper that she showed. Another concern is that if we rely too much on these programs and algorithms, this will reduce the skills of the embryologists and physicians. And there are studies already published showing that the use of AI in different fields in medicine does have this effect. If you don't have to grade your embryos, you forget how to grade them, you don't annotate them perfectly, and this is some concern. So we're afraid that there will be over-reliance on the capabilities of automation. Also, there's big questions about regulating, because these algorithms improve all the time. We see another 10,000 embryos, we improve the algorithm, but when we went to the regulators, we got approval of an older version of the algorithm. So this is new to us. Also questions of liability. Can you sue a machine? So who are you going to sue if a patient said you made bad decisions? The embryologist, the AI program, or the company who made them? And of course, this is a screening tool, which is a limitation. You don't actually get a diagnosis. And again, we haven't yet had the chance to evaluate mosaicism in a good way. And again, it's not a diagnostic test. But to summarize, and this is my last slide, it has clear clinical benefits. If you make better choices, you shorten the time to pregnancy. This can help you in a wide variety of situations, and it's a valuable alternative. Provides crucial embryo quality information, and this, of course, can optimize the way you work and reduce costs. And again, as a physician, where I don't actually make a lot of choices which embryo to put back, I can consult my patient better. Because if I tell her we froze 3 embryos and each one of them has a 90% chance of being haploid, I can tell her what the chances are. And should she freeze more embryos, and so on. So we find it as a very effective clinical tool. And I'll add one slide, because this was discussed in the previous session. It was mentioned, the fertility index, and we know you need a replacement rate of 2.1 to keep your population viable. What this slide shows you, they put in all the Western world countries, okay? And the only country which has a fertility index which is viable is Israel on the top. We actually think it's 3.2, not 2.9. And Greece is down below with 1.4, and some people think it's 1.2. So this is a big problem, and I think as fertility doctors and as embryologists and everybody in the team, we have a big demand to improve this fertility rate. So again, I'd like to thank you. Bye.
Professor Seidman and Dr. Gilboa, thank you very much for your excellent presentations and your amazing work that we all feel that moves IVF into the future.